And last but definitely not least, Alessandra Ferri is going to speak to us about exercise as medicine in people living with motor neuron disease. Thank you, Alessandra.
Thank you for the introduction. And I would like also to thank you, MND Australia, for the opportunity to speak about this important topic that I'm very passionate about. So in my colleague experience, many individuals with MND ask about the possibility of doing exercise and inquire about the type and intensity of exercise they can and should perform. But unfortunately, the research in this area is limited. And for this reason, there are not specific exercise guidelines that can guide health professionals in managing these questions. And so many individuals with MND reduce or avoid physical activity once diagnosed due to fatigue, to the reduction of physical function, and also due to concerns about the safety of exercise. But this physical inactivity causes muscle disuse and all the cascade of impairments that are associated with this. And this muscle disuse adds to the loss of physical function that is depending to the disease, is caused by the disease itself. So our hypothesis is that exercise can counteract the muscle disuse and slow the decline in muscle strength, aerobic fitness, and physical function in the individuals with MND. But to be effective, exercise has to be prescribed as a medicine. And just like any other medicine, exercise needs to be precisely dosed based on the pathophysiology of the disease and also based on the characteristics of each individual. And as the concept of exercise is medicine suggests, there is a minimum dose of exercise that is safe and has some health benefits for people with MND. Below this dose, exercise is still safe, but ineffective. And furthermore, the benefit of exercise will be greater by increasing the dose until reaching an optimal dose. Beyond this, deleterious effects such as excessive fatigue, potential overwork, damage, musculoskeletal injuries outweigh the benefits. So exercise needs to be prescribed into this range. But because of the lack of research in this population, we are currently prescribing exercise to people with MND in the minimum dose range. And this minimum dose is the dose that we have used for our Train-ALS project, a randomized controlled clinical trial that has been conducted at Victoria University. People with MND were randomized into groups. The training group the training group will be represented during all this presentation in the orange that exercised for 12 weeks, and the control group in light blue who continued their usual standard of care. People in the exercise training group train for 12 weeks, 3 times a week, 1 hour per session with a patient therapist ratio of 1:1. The exercise training program was set at moderate intensity and was characterized by 50 minutes of aerobic exercise on a recumbent bicycle and at 80% of the gas exchange threshold, also called anaerobic threshold. That is the point where lactate and other metabolites starts to accumulate in the blood. So we make sure that exercise would be below this point, so at moderate intensity. Strength exercise, 25 minutes of strength exercise. Participant performed one set of 10 repetitions for each exercise at 60% of the maximal strength. Again, moderate intensity. And then 15 minutes of balance exercises and 5 minutes of stretching. We had 1 dropout in the control and 2 dropouts in the training. We didn't have any adverse events during the exercise training sessions. The satisfaction evaluated with the visual analog scale was 9.6 out of 10. And the satisfaction was about the exercise training program. The adherence to the exercise training program was 86%. This means the participants completed 31 sessions out of 36. And 5 out of 6 participants in the training group continue to exercise at the end of the project in a clinic or a gym closer to their house. And below you can see some of the positive feedback that we received from our participants, from the participants of our study. Okay, the first outcome that we wanted to measure was aerobic fitness. And this was because in a previous study that I conducted in Italy, we found that the aerobic fitness measured as a VO2 decreased in people with MND, was decreased in people with MND. And this was caused particularly by a reduced capacity of the muscle to use oxygen to produce energy from the blood vessels. And this value was calculated with a non-invasive tool called near-infrared spectroscopy. For our Train-ALS study, the same value, so this maximal capacity to extract oxygen, was significantly increased only in the training group. But this improvement did not result in also a significant improvement in the aerobic fitness, even despite a 12.5% in change. The second outcome was the muscle strength. This graph showed the maximal strength for the leg extension exercise in the training group in orange and in control group in the light blue. We found a significant increase in the muscle strength by 40% in the training group, while the strength in the control group did not change. We found similar results for the muscle strength for the leg press exercise, with an increase of the maximal strength in the training group by 50%. For the bicep curl, we found a significant difference in the change in percentage in the training group with respect to the control group only for the right arm. And the third outcome that we measured was the physical function. The physical function was measured with the 6-minute walking test. That is a test where participants walk for 6 minutes, and we measured the distance that is covered in this time. We didn't find in both groups any change after the 12 weeks intervention. But interestingly, we found that the maximal strength produced during the leg press was significantly strongly correlated with the 6-minute walking test. So we're thinking that maybe increasing the number of participants could result in a stronger result for this parameter. And we measured also the timed up and go test. And also for this test, we didn't find in both groups any significant changes. But I would like to highlight that any increase in the time of performance of this test indicates a poorer performance. So all the results that I presented here today are just preliminary, and we need a higher number of participants to confirm these results. But even if preliminary, these results that positive suggest that exercise is beneficial for people living with MND. And the improvement of the leg muscle strength that we found, that we indicates that exercise can counteract the disuse of the muscle that are not affected yet by the disease. Exercise is medicine also for people with MND, so the exercise needs to be precisely dosed and tailored to the characteristics of the disease and of each person. And more research is needed with a higher number of participants, so we can really understand what is the role of exercise in the life of people with MND. And for this reason, and maybe also to think that in the future, exercise could be included in the multidisciplinary care of people with MND. And for this reason, we are currently recruiting and conducting a research trial, another one on exercise in people with MND, so you can share my detail with anyone can be interested in this. I would like to thank my collaborator from Victoria University, for Calvary Healthcare Bethlehem, and from Italy, the funding body, but particularly all participants in the Train-ALS study for their time, their interest, and their enthusiasm. And thank you very much for your attention.
Thank you very much, Alessandra. We've got time for one question before we have our closing remarks, I think.
Thanks for doing this research. Obviously, people will come in with different levels of fitness already. So how are you going to, in the future, look at what you should do at different points along the spectrum of MND and control for different fitness already before they come in?
Yeah, I think that this is a great question. I think that we need a higher number of participants so we can really randomize and divide them depending on the stage of the disease in which they are. But at the moment, it's quite difficult to find participants that can commit to this kind of research. And so we are at least understanding if the exercise is safe, it can have health benefits. So our spectrum of participants, for example, based on the ALS functional rating scales, is quite different. But we accept everyone with the ALS is one of the inclusion criteria or exclusion criteria is minimum ALS functional rating scale of 24. So it's quite different anyway from 24 to 48. So the spectrum is quite wide, but we are proposing, so the intensity of the exercise is the same for everyone, but it's a relative intensity. So the absolute intensity is changing for everyone. We modify exercise by modifying a range of motion, but we are prescribing exercise, a similar exercise to everyone, so not depending to the stage of the disease.